Hey, good morning. Good morning, Treasure Coast. This is Pat Sacco, and we are on the forum. God, it just seemed like we were here 2 days ago. Here we go. I keep seeing you every couple of days, but it's really a week at a time, I know. And we have back with us again, Dr. Joe. Where's Becky?
Yep, I'm a regular on the show
He's a
now.
regular
This
on
is
the show,
I think my
yes.
third time total. Second, well, I guess this is the second consecutive month. So this will be our regular segment once
Right.
a month. What is it? First Thursday.
First Thursday of every month.
month,
Unfortunately, I
you'll
don't
get
want to say
me.
I conned him, but I enticed him to come and talk about his practice. And my golly, we could spend 10 hours going through all the things you do. Well, we're going to spread that out for the year.
Yeah, and hopefully give some education too about just general medicine, orthopedics, some common myths and misconceptions, and just get you some education and hopefully some questions that you've been wondering about and get you a little bit more informed.
Right. And I would hope that you all would listen very carefully and know that Joe will be on every first Monday of every month.
First Thursday.
I'm first Thursday.
Thursday.
So first Thursday of every month, and save up your questions. You might think of something. Call in. Get some information. It's free to you. You don't have to pay.
Free consult.
You don't need a Medicare card or anything. Free consult. Well, okay. Here we go. You had some ideas you wanted to transmit a little bit.
So real quick, for those who haven't heard me before, my name is Dr. Joe Wierzbicki. It's a difficult Polish last name. So a lot of my patients call me Dr. Joe or Dr. W. The easiest way to say my last name is where is Becky? Where's Becky?
Where's Becky?
And I am a non-surgical orthopedics. My specialty is injections. And I work with Florida orthopedic specialists. And we have two locations, one in Port St. Lucie and one in Stewart. We're on the corner of Highway 1 and Walton Road in Port St. Lucie. And then in Stewart, we're close to Indian Street and Highway 1, just a little bit west of there. And I'm in the office every day of the week seeing people. I'm the non-surgeon, and so I see people same day and help to expedite some service. And if you want to give me a call, see me in the office, my telephone number is 772-335-4770. And my website is easy, doctor, all spelled out, w.org, drw.org. And that's where you'll find me and my wife. My wife is also a dentist in the area. She focuses on cosmetic dentistry. And her name is Dr. Bethany Wierzbicki. And you'll see her there on the website also. And so let's see here. So last time we just spoke a little bit about some general orthopedics. But this time we're talking a little bit more about the spine was our plan for today.
Right. Oh, one thing I would interject. I'm just looking here a second. Go ahead. I'll find what I'm looking for.
Sure. So we'll do a little bit more of a deep dive into the spine today. And the spine is a pretty important structure. Reason is it houses your spinal cord. And spinal cord, very important for controlling nearly everything in the body. From your heart, your lungs, the way that your intestines operate, your hormones, and then, of course, the muscles, the tendons, the ligaments. I'm having a little bit of a tough time breathing with this mask.
We don't usually talk a lot with a mask.
Yeah. So sorry if I'm catching a little out of breath here, but the mask, it makes it tough.
Well, take a breath a minute. I'm going to give a phone number. If you want to call in and ask Joe a question, it's 220-9788. 220-9788. And today's a momentous day, and I'm going to get to that later, but go ahead.
You're breathing funny now? With the mask on, when you take a big breath in right away, the mask kind of suctions into your mouth like if it was a plastic bag over it. And so you can't get big air in really quickly.
Well, the other thing is I have to complain about this mask myself because I wear glasses when I read. Mm-hmm. And I was sitting out in the lobby there reading, and all of a sudden it got foggy and didn't get foggy. It got foggy. As I was breathing, my breath went through the top of the mask and fogged up my glasses.
Oh, yeah. Yeah, common problem. I see it all the time in my clinic with the people wearing their masks and their glasses, and they have to take off their glasses or manipulate their mask.
Oh boy, I know.
Yep, problems. Yeah, but anyways, we're talking about the spine, and most people know about what our spinal column looks like, all those bones that go down there. But there's a couple important things about the spine and the way that it's built. One is that within that bone, within that vertebrae, there's this central bony cage that protects the spinal cord. And then there's another separate bony cage for where the nerve leaves the spinal cord and leaves the spinal column and goes out to either your arm or your leg, whatever level it's going to. We have many different nerves that are leaving the spinal column. And so these bony cages in this protective area, it's very important that you have lots of space for the spinal cord and for the nerve. And it's a problem when people develop herniated discs or arthritis that turns into bone spurs. And then various things can encroach upon the nerve or the spinal cord. And that's where there's major problems because, of course, we need our spinal cord and our nerves to do things like, control our hand movement and our fine motor control our legs and our reflexes and our ability to balance and walk. And so as these wear and tear changes start happening, it leads to more and more nerve dysfunction. And nerve dysfunction is not good on it by itself. And then if it leads to permanent nerve damage, that is an even bigger problem because permanent nerve damage, like it says in the name, you can't repair permanent nerve damage.
Right.
Yeah.
Go ahead, Pat. As a successful surgical person, years ago, I had a spinal fusion of L5S1, which I was told is the heaviest weight bearing of the spine, where it begins to tail off to the coccyx, the tailbone.
Yep.
And that was not a pleasant thing to go through.
Yep. No one ever wants spine surgery, and everyone has heard horror stories about spine surgery. Maybe they've even heard percentages broken up into 33, and 33%, or 50% and 50% about the number of people who get better, who are no better, or get worse.
Right.
And part of what I warn people about is part of the reason why those numbers are what they are is there's a lot of people who are getting spine surgery who really aren't the best candidate for spine surgery. Surgery, and again, I'm painting with a very broad brush here, but surgery is meant for nerve impingement. It's meant for spinal cord impingement. Surgery isn't successful for true arthritis, back pain alone. Surgery is more successful for those other things. And so when you really break apart those numbers, a person who has spinal cord pinching or nerve pinching, and it's not getting better with non-surgical treatments, those are people whose surgery will be much more successful for.
It's more toward the mechanical side.
Yep.
Of reinstating or correcting an injury or correcting an impingement.
Yep, exactly.
Rather than the arthritic condition.
Yeah, and what surgery is also not successful for is for muscular issues. And anyone who has a problem with a herniated disc or a pinched nerve or arthritis, you all have muscular issues. It is impossible to not have that. Unless, of course, you're just talking about maybe a 15, 20-year-old kid who maybe tried to lift an Olympic-sized weight and herniated a disc. Maybe he doesn't have a muscular issue in their back, but everyone else, there's been multiple damages to your back over the long course of time that leads to a malfunctioning dynamic muscular control of the back. And if that's not functioning properly, well, then you're set up for muscular issues. And a lot of muscular pain is at the core of a lot of arthritis pain too.
Right. And the way it's been explained to me with several physicians and a chiropractor as well, that once you have spinal, so let's say my L5S1, the lowest large vertebrae, okay? Now, the load that junction had taken care of now is moved up to the next vertebrae. That becomes more of a load factor. When that goes, it moves up to the next vertebrae, which we can, and eventually I've been told you end up with rods and all those things in your back because your back was not designed for any one vertebrae to take on more of a load than it's supposed to take on.
Exactly. That's a great point. This is a beautifully built system that we have. And when you start tinkering with Mother Nature, things can accelerate and go in a wrong direction very quickly. So you mentioned when you had a fusion. So normally those two bones that are now fused together, a spinal fusion, normally those bones would have range of motion. They could go left, right, front, back, and twist. But when you fuse them together, well, we're still going to do those motions. We're still going to test our back and our body in that way. And so where that extra motion and extra friction comes from is right above and right below that. And so those joints above and below you wear out very quickly after you have a spinal fusion like that. It's a adverse event or it's a risk, but it's oftentimes a necessary risk when someone has that much pinching of the nerve of the spinal cord. And it's just something to be aware of. Now, when it's more important is when someone is younger and needs this, because we need to warn them, hey, 10 years down the road, 15 years down the road, your back, your spine is going to be in a tough spot because we're altering those mechanics. And that's why surgery is nearly always last resort, especially with the spine.
I've got a cute anecdote. The surgeon I had was from the University of Rochester, Strong Memorial Hospital, a world-class surgeon. And summers he took off to Asia and taught techniques. I went in and I had an x-ray. It was a follow-up from the surgery, and they handed me the x-ray and said, take this to the doctor, and then told me what room to go in. So of course I turned the light on, slapped the x-ray up there. I was looking at it. He came in and I said, what did you do to me? He said, what? He said, you told me there were going to be bone chips in there. I said, those are not chips, those are chunks.
Oh, yeah.
And that came from my iliac crest.
Chips, yeah, we like to,
I think chips are little.
Choose the proper terminology.
Thinking
like
ice chip.
Yep. There's going to be just a small pinch with this needle, or small amount of pain. Yep. We like to choose our words carefully, and but sometimes we may err on the side of a little bit of a sugar coating. Yes.
Well, I didn't know this at the time, but it actually helped me because a month before the surgery, they did a plaster cast on me and split it down the middle, put some Velcro on it, and said, wear it for a month and let's see if it helps. And it did. So I had the unit at home, and after the surgery, I said to the doctor, I'd like to go home. He said, no, you have to wait because we have to put the cast on and everything. I said, I have the one at home. He said, okay, I'll make a deal with you. If you wear it when you're sitting, you don't have to wear it. Anytime you get up out of a chair or out of bed, you put that cast on and Velcro it, which I did. So I at least had the freedom of sleeping without this cast or sitting in a chair without it.
Yeah.
But that was 4 months. And now they have those beautiful plastic supports.
You know,
it isn't
about the ones that like the movers are wearing, the ones that kind of strap around you and Velcro and pull tight.
And plus the big plastic things that, on both sides.
Yeah, for the stabilization. We have some really good braces now. And actually that brings up a common question that I get is, well, if I'm using the brace, isn't that going to lead to weakness? Maybe someone has told them that. And so, that is a concern. But really the way that I like to think about that is, as long as we're not depending on it 24/7, then you're not going to develop the weakness as long as you're also doing some things to strengthen those muscles. And we just use this as a short-term crutch or a short-term Band-Aid. Now, that's for the large majority of people, the way we look at it. Some people, they do need it chronically just in order to live, in order to have that control and give them pain relief. And so don't worry as much about it producing weakness or secondary issues. Worry more about what's going to help to give you pain relief. And for some people, the back brace can help. And especially if you've had something like a surgery or a fracture in your back, then it is needed for short-term healing. Yep.
What about injections in the back?
Great question.
Cortisone.
Yep. So I'm the injection specialist.
Right.
I do
That's
a
why I brought it up.
lot of injections. Now, for the large majority of our joints, the elbows, shoulders, knees, those are very easy to inject. And the reason is because there's no nerves or spinal cord around them. We know how to find a way to put that needle in a very safe way so that we don't injure something important like your spinal cord or your nerves. Now, with the back, it's a little bit more of a delicate area, of course. So always before someone has an injection around the arthritis in the back, the disc, or the spinal cord or the nerve, you need an MRI. And for people who can't have an MRI, then there's some alternate tests that can be done. Now, that's excluding people who need an injection in the muscle of their back. That's different. But before putting an injection around, like I said, the nerve or the spinal cord or the arthritis, you get an MRI because these levels, there's a lot of overlap between where is your pain coming from? Is it coming from level 4 or level 5? We can't really say as reliably with a person's symptoms and with the physical exam because there's so much crossover. And so the MRI is very helpful at telling us where there's more active damage and where that needle will be most beneficial. Now, a lot of people are concerned too about going in and getting an injection in their back. It sounds kind of terrifying, but don't worry. People who do these injections are extremely well trained. You're going to, after medical school, you're going to additional post-medical school training like residency for about 4 years, plus doing an additional year of specific spine-only injection training. So this is all these spine injectionists do. And actually, this is the one injection I don't do. My partner does them because I don't have that extra year of training. And so he does. And so he does these injections for us under X-ray guidance called fluoroscopy.
Mhm.
So these are under the umbrella term of epidural injections, or there's some finer terminologies that people may hear about, like rhizotomies, which is an alternate type of injection in the back. But like you were saying, injections in the back, we can talk about all the different types. So I just want to go back first here. People's fears about these injections. I have never heard of someone truly having a disastrous, permanent adverse event from an injection, like an injection in their neck causing paralysis or causing permanent damage to the nerve. Yeah, some people, that needle does come extremely close to that nerve and can cause a lot of pain, and the nerve can regenerate itself. But I've never heard of someone being paralyzed from this if you're going to a person who has been very well trained. And our doctor, Dr. Williams, is extremely well trained. So I would not be fearful of that. The other thing is that we need to take the appropriate precautions. Before you get an injection in your back, there are certain medicines you should not be on because that can lead to a complication. For example, blood thinners, or if you're taking too many anti-inflammatories. If you put a needle in the back and you're putting that needle right next to the nerve or the spinal cord in order to get that anti-inflammatory effect, and right, we are carefully monitoring where that mechanical object is going. But if by doing that you start bleeding in that area, well, then you can build up a hematoma, which pushes up against the nerve of the spinal cord and causes even more compression and problems. Now, we can avoid that if people have a normal coagulation system, but when medications are in the picture, that can be a problem.
Well, you'd have them, I don't want to say titrate, but basically come off of that medicine for a couple of days to build up your coagulation.
Exactly.
As I have to go through,
I'll be,
I'm getting my 4th pacemaker. It's like being in the Army. I have chevrons, and I have all these little strips, those streaks, and they'll probably take me off my warfarin for a couple of days to get my PT-INR would be like a 1.5 instead of being between 2 and 3. Get it down to add some coagulation.
Yep, exactly. And so it's important that everyone follow the doctor's instructions.
Exactly.
If the doctor tells you don't be taking ibuprofen, the morning of, and you take it, well, then you're more prone to having problems with that injection. So, as always, listen to your doctors.
Right.
So the injections. So there are multiple spots that you can put a cortisone injection in the spine. You can put it around that exiting nerve, like I talked about. You can put it in that central area where that spinal cord is. You can put cortisone around the arthritis area. Those are the 3 main areas. Now, those are all what I would just call an epidural. Technically, they're not all epidurals, but let's just call them an epidural for the sake of ease. Now, other injections that you can get in the back. This is a common term called a rhizotomy. And what a rhizotomy is a burning of the nerve around the arthritis part in the spine. So before someone gets this kind of injection, we put a test injection in, lidocaine. It's a temporary numbing agent of the nerve. And if someone gets success with that, well, then they would be a candidate for us to put a needle in, and at the tip would be a heated portion to more or less disable that nerve. What it does is it stops the pain signal from going from the arthritis part in the spine up to the brain. It's kind of like putting a gap in that road that sends the pain signal from the arthritis spot to the brain so that you don't feel as much of the arthritis pain. Yep. Now, we don't want to go around just disabling nerves, but this is an okay nerve to disable in people who need it because that nerve doesn't control anything else. It's not controlling the muscles or your reflexes or your legs. Its only responsibility is sending that pain signal from arthritis to the brain. So that's something called a rhizotomy. Other people may call it by the brand name COOLIEF. I think those are the major injections right there. Outside of that, it's much more rare injections or procedures that are non-surgical in the back, like spinal cord stimulators, which not many people are candidates for, but it's something that we do, a few times a month.
Well, people, I think, get queasy when you talk about injections to begin with. You're going to stick needles in me? Of course. How else are you going to get this?
Yep. I mean, we got to get you some pain relief.
Exactly.
So, Yeah,
And
in
plus,
the spine,
the
it's
needles
much
are
more.
not big, long.
No, yeah, we do everything possible to minimize the pain with it. And
Right.
some people, they even need a little bit of light anesthesia in order to get this done. So, like I said, all of our other joints, I do the. I mean, if you came into the office today and needed an injection in your knee, heck, in the next 2 minutes, I have my ultrasound out and I'm doing that injection, boom, and you're done and you're out the door. But with the spine, we have to take a little bit more precautions because of how delicate
Right,
that area
right,
is.
right.
Yep.
Well,
Mhm.
I've heard it said that we've made all kinds of advancements in most of our body except for the spinal cord.
Yep.
The
It's
advances have not kept up with the other advances in medicine in our body.
yeah, and you know
It's a
why
very
that is?
complicated system, though.
It is,
Also,
it's so many joints
yeah.
all in one. It's so many muscles that are controlling these small joints. And on top of that, it's a very delicate structure that doesn't have the same regenerative capacity as the rest of the body tissues. So I think that's partially why there is some hope for things like stem cell therapy. And I've seen some miraculous case reports about people getting a stem cell injection in their spine for chronic nerve damage and getting healing from that. But
Hmm.
we're not quite there yet on the main scale. But you're right, the spine, we're not making as much progress as we are the rest of the body.
The little that I've read and the little that I've been exposed to, it seems like stem cells might be the answer to so many problems.
They really are. Now, and I do
It's
a lot
like
of
being an
stem cell
autologous
injections.
blood donor. You're storing your own blood after surgery that you need your own blood. Wards off a lot of problems with getting blood from someone else.
Yep. And I do a lot of stem cell injections for various parts of the body. Of course, I don't do it in the back, but I do talk about it with our back injectionist about stem cell injections for the back. And outside of people who are taking that long shot of trying to get stem cells to heal chronic nerve damage, we're not using them all that often in the back. And the reason is because it's not as successful by the research. And also there tends to be other problems that the stem cells can't help in the back. Now, eventually that may be different. In the rest of the body, they work much better. Like the knees, for example, we put an injection in the knee, and I'd say when you look at the research and compile all the numbers, more than 50% will have really great results with a stem cell. And there's multiple different types of stem cell therapies that we do. But the problem with the stem cell, and why I still think that there's a lot of hope for future stem cell treatments, is I don't think we currently have the formula right for the stem cells. What we're missing is we're missing that ability to tell this stem cell that could become cartilage, liver, bone, tendon, brain tissue, any number of tissues. We're currently missing that ability to tell that stem cell to become the kind of cell that we want it to be. If we're putting it in the knee, we want to be able to tell that stem cell to turn into cartilage and meniscus cells. But right now, we're not there yet. Scientists are working on that. But again, that's the missing factor. And once we figure that out, I think stem cells are going to be a major game changer and are going to help a lot of people's arthritis.
And it's going to be a lot more simple treatment, less invasive, certainly less
much less
surgical
surgeries.
intervention.
Oh yeah, it'll be great for me as the injection specialist.
Right.
I would venture to say no one in the country does more injections in the body than me. I mean, I'm the knee injection specialist, and everyone in this area has knee problems, and so I'm probably doing 2 dozen knee injections a day.
Well, it's the specialty, and again, I have to go back to me because I'm a very selfish person. Whenever I need a medical intervention, a medical treatment, a medical diagnosis, I go from the top to the bottom. I don't look at a person having an MD. That's the base. I look at where else they've been and what they've been trained to do. Are they board certified? The successes they've had. I'm a terribly picky person.
Yeah.
That's one of the reasons I jumped on to Dr. Where's Becky, by the way.
Yeah, and you know, and everyone's going to look at problems differently. You know, the old saying, "When all you have is a hammer, everything is a nail." That in some ways applies.
Very
We all
good.
have biases. We do. And so
well, I think I'll
surgeons are
try
gonna
it.
be
I haven't
biased.
done that in a while. It's kind of like pacemakers. I give a plug to him, who comes to what is now Cleveland Clinic, Martin Memorial Hospital, Dr. Brewer from Abacoa, and lines up on Wednesdays. I think, I don't know how many pacemakers he does. He comes in and does them. He's the man. He's the expert. The fellow who did my cardiac catheterization, Dr. Warshel, is at Palm Beach Gardens Hospital, invented some specific procedures to make this system better. I'm looking at those kind of people, and fortunately, if I can find them, get into them. That's why I had Dr. Chang, who was this world class surgeon. I found, and I think we have to be picky. We have to go around and find the best person for the job. If you're doing 50 injections a week, I want you rather than the guy who said, "Oh, I did one last month."
Yeah, I learned one in school. Yeah.
Yeah.
And especially with these problems, and we're all guilty of it, even
But
me, of playing
specialists are
doctor.
there because of
Yep.
that.
Yeah.
Okay,
Yep.
that's their job.
We all monitor our symptoms and our body and kind of, do our checks and whatnot. And we think we know what's going on. For example, someone's coming in with foot pain and they think it's coming from their nerves. And so they think that this is a neurologic problem. And so they go to a neurologist. Well, part of that problem is when it's not absolutely clear what your pain source is. You should really start general. Start with the primary doctor, get his opinion on it, see how he asks you questions, he or she asks you questions, and then see what their opinion is. And then oftentimes you want to start there. So if he thinks it's coming from a neurologic structure, great, then you're off to the neurologist maybe. But if he thinks, no, that's actually coming from a type of plantar fasciitis issue, this is more orthopedic. Start these things. He may tell you, do these exercises, take this medicine, do these things. And then if it's not getting better, or if you want right now, you go to the orthopedic doctor. Otherwise, you can end up kind of misstepping and doing some improper treatment if you go to someone who's maybe more prone to bias.
It's like if you have a torn retina, the ophthalmologist may refer you to a retinologist.
Mhm.
The ophthalmologist probably can do it. However, that retinologist has that specific training that goes beyond the ophthalmologist training.
People will come in and see me for kind of some mid back pain, like almost pain along their shoulder blades. And as I'm talking to them, this is actually sounding like it's coming more from a pneumonia or maybe some type of heart issue. And I'm saying, no, go back to go, stop and go back to go, like that old saying. And I'm saying, no, you need to go to the primary doctor, the urgent care, because to me, even as an orthopedist who has biased thinking more things come from the muscles in the back, this is sounding too much like that. So start over and get their opinion first.
How'd you get into orthopedics?
I actually was trained in general medicine first.
Yeah, I know that.
Yeah. So after medical school at Kansas, getting my MD there, I moved down to Florida. And so I did family medicine residency for 3 years with a focus on sports medicine.
Right.
And then I did a fellowship in non-surgical orthopedics and injection management. So I like it because it kept me broad. And even now it's still helping me to serve my patients. Maybe they're doing something improper, taking their acid reducer improperly, or not paying attention to their preventative care and getting their colonoscopies or whatever they're doing. I can help to offer some tips. And again, it helps to keep my treatment broad. Someone's coming in with something that sounds like lung infections. I'm more able to pick that up than your standard orthopedist who hasn't seen that since medical school.
Especially with the Tampa Bay Buccaneers.
Yep. Oh yeah. Yep. I enjoyed my time with them.
What did you do with them?
Well, I'm a big Buccaneers fan. And so so I assisted their staff back when I was in fellowship around 2012. A long time ago. I got to meet some really cool celebrities back then. And really, it was more a lot of preventative things, talking with the physical trainers, making sure that they were on the right programs, the athletes, doing their exams and making sure that there was nothing going to hamper them going into the season, like maybe a medication issue, or they weren't rehabbing properly, or maybe they were more prone to something like heat stroke. So we did a whole general medicine and orthopedic thing with the Buccaneers.
Neat. Okay, we're going to break for our little commercial and we'll be right back.
All right.
back again on the air. We're just laughing about football.
Yep.
So you
Right
are
around the corner.
You are a
Yep. Oh yeah. So
fan.
for those people that are just joining us here, I'm joining Pat, and I'll be doing it the first Thursday of every month. And I'm Dr. Joe. Where's Becky? Like, where is Becky? Where is Becky? And again, you can find me here in Port St. Lucie and Stewart with Florida Orthopedic Specialists. Our telephone number is 772-335-4770. Or you can find me on the internet at Dr. all spelled out W.org. drw.org is where you'll see me and my other, the other Dr. W, my wife, Dr. Bethany Where's Becky, who's a cosmetic dentist in the area.
Right.
And you'll see it from her smile. She's good at what she does.
Yeah, she better be.
Yeah, so you can find us there. And today we're talking orthopedics, sports medicine, general health, a little bit of everything.
You can have her on the air at some point.
Yeah, that'd be a great idea for her to talk about some dental subjects.
Absolutely. By the way, I always refer to your place as across from Eastport Plaza.
Yep.
Because people
Right
don't
across from
know
the Civic
US
Center.
One numbers and things. It's right across the street from them.
Yeah, we're right at that crossroads of Highway 1 and Walton Road in Port
Right.
St. Lucie. And in Stewart, we're on Highway 1 and Indian Street, just a little bit west of there by Willoughby Golf Club.
By Willoughby. Right.
Yep. Yeah. And again, that number, it will connect you with either clinic, the 335-4770 number.
I've done a lot of work with what used to be Allegro, which is now Eddington Place, which is on Indian Street, Esther Lane, the first light.
Mhm.
And then down on the
Yeah,
left
it's right there.
before the bridge is a unit that does dementia patients.
Mhm.
So, I'm familiar with that area there.
Yeah, I know what you're talking about. Well, great. Well, where did we leave off from before? Do you remember what we were talking about with the spine? We're kind of talking everything spine and little tangents here and there today.
Yeah.
We were talking.
Yeah,
we
we
talked
got
about
into some
injections.
things that I didn't think we were going to get into right now, but that's okay.
Yep, we talked about general medicine things and what I do. We talked about the injection. So surgery. So like I was saying before, a lot of people have this misconception that surgery could make things worse. But if you're an ideal surgical candidate, meaning you have more nerve pinching issues, you are more likely to have success with surgery. And the other thing I'll warn people about too when it comes to the spine is I talked about at first with this herniated discs and bone spurs and arthritis, how it can cause nerve pinching, and that nerve pinching causes inflammation, and that inflammation, right, temporary nerve dysfunction. But if that continues, it can go on to permanent nerve damage. And like I said, we don't like permanent nerve damage because even if you take out some of those calcium deposits and do surgery on it, that permanent nerve injury can still be there. So one of the common things we talk about is carpal tunnel. So that's pinching of a nerve going through the wrist. And if people go on to develop weakness in the hand, that leads to muscle atrophy because the nerve has been permanently damaged. And so even if someone gets carpal tunnel surgery and that nerve now has room to breathe, well, the permanent nerve damage may have been done, and you may still be left with chronic neuropathic pain, neuropathy, and weakness in the hand. Now, the spine is even more sensitive. And so if chronic nerve damage happens there, then you may be stuck with things like balance issues, fine motor control, being more prone to falls, having endurance issues in their legs. And so if someone is having issues like that, it could be coming from the spine. And I encourage people to not let that go unchecked, because I just hate for something to turn into a permanent problem.
Right.
Yeah.
In other words, there are certain nerves that will regenerate and certain nerves that will not regenerate.
Yep.
Like the optic nerve.
Yep, exactly.
And it would be great if it did regenerate. If you have damage, remember in one of my anatomy classes, we'd looked about the diagram of the pathways of vision trouble, where it occurred along the optic nerves.
Yep.
Fascinating, because I did see people with homonymous hemanopsia. One-sided on both eyes, or upper right quadrant blackout.
Yeah.
Fascinating things that how they studied that to come up with those specific things. But again, those are not regenerative.
Yeah. The nerve, certain nerves can regenerate as long as they haven't been injured too much. And again, it depends if it's part of the spinal cord or part of the nerve in your arm. And that's why people who've had neck issues, continue to have paralysis. It's because we can't get that spinal cord to regenerate. And we're working on some things, but I still think it's years off before we're seeing anything to regenerate the
cerebral
spinal
vascular
cord.
accidents.
Yep, exactly.
That will zap out a section of the brain, and And again, that's not regenerative.
Yeah, it's really not. And certain people just say, well, I have these issues, but I just can't undergo a surgery. My heart is too bad, my lungs, my doctors don't think that I would make it out of surgery.
Right.
And well, that's a conversation to have. And there may be other things that can help to give you some quality of life related to your spine or your symptoms that can be done, even if it's not surgery. And that's where we come back to things like the injections or the therapy or using the right kind of walker or maybe a certain kind of medicine, like a nerve silencing medicine. There's lots of options. And yeah, we may be out of options with certain people, but at least we tried it. And if you haven't tried certain things, well, then what can you lose, really?
Right. I'm a prime example of that. 16 years ago, after my open heart surgery, the surgeon told my wife, better not have this surgery again because you're not going to survive. However, I had a mitral valve replacement. And now I understand they're doing mitral valves through the chest, through the ribs.
Yep. And there's
rather than
different
opening you up.
Yeah, and there's different intensities of surgery. It depends on how deep you have to go
There's
under.
a clip thing that goes into now with the mitral valve.
Yeah, and with your pacemaker, I'm sure they're just giving you some light anesthesia or maybe even just local anesthesia sometimes if they're just changing out the unit.
Oh yeah, that will happen. I'm toward the end of this one now. It's a biventricular. So they put an extra wire in, so I'm getting stimulation on both sides of my heart, rather than the regular pacemaker was one side with a ground wire, and that's improved my injection fraction.
Oh yeah,
a lot. I mean, it's significantly, which gives me more energy, and
Yeah, so there's different risks with different procedures depending on, how long the procedure is, how much anesthesia you need, and what you're operating around. And that kind of brings me to another point too that I like to tell people. Some people will shop around their opinion for what kind of surgery should be done in the back. And they may hear one surgeon say that it's going to be a 10-hour operation and he'll just go through the back. And they may hear another surgeon say, no, I don't think that surgery is best for you. I think we need to go in the front and go in the back and maybe put a plate in. And oftentimes what I hear is that people tend to go with the surgeon who recommends the least invasive. And the problem with automatically doing that is if you don't get the proper procedure done, then you're not going to get resolution of your symptoms. And I'm not saying that the more in-depth one is always the right one, but you just want to consider that and try and protect yourself from yourself. The less is not always more there. Another thing that people always get scared about too with the spine surgeries is with the neck surgeries, we actually don't cut in the back. They go in the front.
Right.
Yeah. We always want to not cut muscle if possible. And that's part of how my group and Dr. Powers and the other surgeons there got famous was because they were one of the first people to start doing muscle sparing surgeries for the knees and the hips. And if you're not cutting the muscle, you heal that much faster. So that's very important if you can go to someone who does a procedure without cutting the muscle. Now, some procedures you just have to. Part of the shoulder procedures, you have to cut the muscle. In some of the back procedures, you have to cut the muscle. But in the neck, they found a way around that. And so instead of cutting through the muscle in the back part of the neck, you come in the front where you can move those structures to the side, like part of the side neck muscles and part of like your vocal cords and your esophagus. And you can see straight back there by just pushing things to the side a little bit. And people do great with neck surgery. And it sounds so scary coming in the front.
My sister-in-law had neck surgery and they went to the front.
But it's actually one of the safest things.
Sure.
And again, surgeons like doing this one because patients are so satisfied with the result and the recovery tends to be so much quicker than a lot of our other surgeries.
Amazing. It's amazing. Again, see, that's why I said originally we need to, I hate to use the term shop around, but I think we need to shop around. We need to go to a second opinion with anything serious.
Yep.
Okay. And compare the two explanations we've gotten from the two surgeons, for instance.
Yep.
And, decide what is best and why would you not do something or why do you do something?
Yep.
Like you said.
Yep. Oh, yeah. And, people come to me all the time like, hey, do I really need a knee surgery right now? Because they may have seen someone else that said, yep, you're bone on bone, forget everything else. You need the knee surgery. And they come and see me and they haven't tried any injections, or maybe they're not in that much pain. And I'm saying, why are you going to get a surgery if you don't really need it? Now, you may need it because you failed all those things that I'm going to bring up and your pain is that bad and you are bone on bone. Well, then, you feel that much better going into surgery. But there's this old thing, there's no problem surgery can't make worse. And so you do want that problem to be pretty bad, either medically or symptom-wise, if you're going to undergo a surgery. yeah, it's a low percentage chance of someone having a surgical complication, but still, something like a knee replacement, there's a 1% chance, well, 1 to 2% chance that you're going to have an infection or a problem with that knee replacement. And let's say 1%, 1 in 100 is not much, but if that 1% is you, that is 100% you.
Exactly.
And that is 100% a big problem if you get an infection in your knee. And some people come into me saying, why did I ever get that knee replacement? They're kicking themselves saying, I never tried the injections. I wasn't in that much pain. I wasn't having that big of a problem. And now my knee is in pain and I've had infections they should have gotten an opinion with a non-surgical person first.
You have to be careful of percentages.
Yeah.
10%
They can be manipulated.
10% of our workers in America are unemployed. How many people is that? That's the point.
Yep.
That we're not. When you say percent, you're talking units.
Mhm.
When you're talking people, you're talking people.
Yep.
And
you got to be very careful with the terms and how you apply those percentages,
Exactly.
like we were talking about last week and how people can modify statistics and make it say whatever you want it to say, really.
Like the spider.
Yep.
Yeah, you can manipulate them for that.
Mhm.
But yeah, gosh, you've hit on some pretty heavy duty pieces of information that I was not aware of. It's a big deal. I wasn't aware of it. Most people are not.
Yep.
And so we have to be very, very careful. We have to choose our people carefully.
Mhm.
We have to seek second opinions if we feel it's necessary, or sometimes the doctor will recommend it.
Yep. And it goes with all of our treatments too. I see, life and medicine, as a lot of risk management, and playing the odds, playing the probability. There's a 1% chance that if you get a knee surgery that it's going to get infected. Well, if you're miserable living with knee pain, well, that is 100% chance that your quality of life is severely impacted and you're not living to your full potential. So, if you've exhausted everything else and you're saying, I have miserable knee pain, I can't do the things I want to do, but I'm scared about a potential infection and surgery, well, that's a 1% thing. I play a lot of risk management and probability with my patients. We can't predict the future, but we can apply statistics to help you pick the best future and minimize the chance of problems, worse problems, and also having the best quality of life.
Well, sometimes it's a little alarming. I met with my surgeon prior to the heart surgery, and I said, what is the mortality rate of this kind of surgery?
Got to ask those questions.
And he said, well, it's 10%, but with you, it's 25%.
Mm-hmm.
I said, why? He said, because you had 2 massive heart attacks.
Mm-hmm.
I said, Doc, I never had a heart attack. He said, yes, you did.
He said, yes, you did. Yeah, it's silent heart attack. Yeah,
because your heart is enlarged and scarred in the back. I said, oh, thank you. I wanted to know that, really.
Yeah.
Because so a lot of times, I felt I was robbed. I was robbed. I didn't get the ambulance ride. I didn't get the flowers and the get well cards.
You didn't get the elephant sitting on your chest and the arm pain.
Right. I had the pillow. I had to
consider yourself lucky. Yeah.
I never got those things. Could have been in my sleep.
Yeah.
But that really threw me for a loop. So, well, wait a minute. I didn't have any heart attacks.
Yeah. And I'm talking about, the risks and percentages and probabilities. And that's where a lot of my talks come down to with my patients is I'm really trying to get in your head, in your body, in your shoes to really feel, what are you feeling and how big of an impact is this on you? How severe is it? And how much does it impact you? Because then I can help to best give you some things that will improve that. If a person comes to me saying, that they're in miserable knee pain, but they're not explaining things right, well, it could only be that they're in miserable knee pain when they go to Disney World once a year, and then their knee is flared up for a couple days. But if they're not explaining that to me properly, I could think that you're in miserable knee pain every single day and recommend a different treatment. So that's why I ask sometimes a little bit annoying questions about, when it bothers you, how it bothers you, and really how big of an impact it is. Now, that helps me to say, wow, this person is really struggling. They're having quality of life issues. Okay, that means that they may need something like a muscle relaxer, which has a chance of causing drowsiness and dizziness, or something like a narcotic medicine, which has the chance of dependence. But if someone has major problems and major pain, well, then it is worth that risk if the current problem is that bad.
Yeah, and that's where these residencies come in to play.
Mm-hmm.
By the time you are done with 4 or 5 years of residencies and developmental specialties, et cetera, beyond the medical degree, you're prepared to be an expert.
Yep.
And that's the
Mm.
point.
Yep,
That was cute. The people that were graduating from medical school in New York City
Mhm.
during the height of the coronavirus, they said, as soon as these guys get out, we're going to put them into work. And somebody said, hey, they're going to be glorified nurses. They don't have experience yet. They don't have all the specialties. They
Yep.
said, that's okay. We'll put them in the hospitals anyway.
Yep.
Were you prepared?
You know, I don't think any smart doctor would ever say that they're ever prepared. You know, it's funny.
No, but I meant after medical school.
Oh, after medical school? No, I wasn't prepared. You know, I was prepared for, I was prepared to be supervised and monitored and guided in the right direction. Yeah. And so, back to what I was talking about risks and medications and whatnot is another problem that I see with certain patients. And I love it when people are on top of their health and they do their research and they learn about their conditions and whatnot. But sometimes we can be our own worst enemy and we read too much about potential side effects. And then by reading those things, you think that the chance of that side effect is higher. My example that I use, I feel like it's every show, I talk about the anti-inflammatories. And people think that, oh, I read this list of side effects, and if I take this Aleve, it's going to give me a heart attack. No, that risk is extremely low, despite how Google is advertising that. I mean, a doctor's not going to prescribe you something that has a high chance of a side effect unless, well, you really need that because, well, the condition is that bad. So people who we prescribe a medicine for that end up not taking it, well, that's a problem because, I mean, then really what was the point of coming to the doctor?
Well, I have one caveat about that. When you look at that, the white sheet that comes with your medicine that has all the potential, this happened, that happened, that happened. I often wonder, was that to happen anyway, regardless of taking this medicine?
You're right.
Heart attack.
Yep.
Was that because of the Aleve, or because it was a heart attack that had
Right.
nothing to do with
nothing
that?
to do with the Aleve.
Because they're
You're right.
monitoring just everyone.
Yep. And the way that the laws are and the legal system is and these medical labels, if someone has a heart attack while they're taking that medicine and being monitored, well, then they have to put that on the label. But these things happen naturally anyways. It's something called the natural frequency. So we have to look at some of these bigger studies and say, well, the natural frequency of having a heart attack for this person is this percent.
Right.
Well, and also this same group of people, if they're on this medicine, it's now this percent. So it's complicated. And all these things are the way the medications can interact in a person's risk factors.
Well, you can take an approach, look, whatever seems to be good for me, I'm going to take it.
Mm-hmm.
And I think we have to put our hands into your hands.
Yep. And
you're the one that's guiding us through these things, and I have to have some faith in you as my physician.
And I'm reasonable too. I have plenty of people who come to tell me they're just set on never taking an anti-inflammatory pill, and they tell me that, and they explain, and I say, okay, all right, let's move on. Let me give you some other options. And I much prefer that than someone who will just nod and smile and then not take the medicine, because then I can't really help you. And so I think that's an important part, is discussing it with your doctor and getting alternatives. And I do hear some horror stories where a person will say, they told the doctor they're not going to take that, and the doctor gets upset. Well, if a person is reasonable about it and explains it to me, I'm never upset with the person. I just want to find a way to help you. And I think that's why some doctors may get upset. It's because sometimes we're held back on how we can help people.
Right. Well, I know you have some neat plans down the road to bring in some of your colleagues to talk about different subjects and stuff. And I want you to be our medical advisor to this program. Obviously, you are.
Yeah, and if there's general medicine questions too, I'd be happy to answer those.
Right.
I know people are emailing you with questions that we're addressing.
Right. And but we'd appreciate anybody who wants to call in or to send an email to generate a question or some discussion. We're happy to do that.
Yeah. So send Pat an email. Next week, I'm going to be bringing on our foot and ankle specialist, Dr. Paul Johnson, Navy trained, very academic, smart foot and ankle specialist and total joint specialist. And so we'll be having a general talk about some of those lower extremity issues. And he's in my same practice with me, Florida orthopedic specialist.
Oh, good. You mean I can get to call in?
Yeah, you can call in and hassle us, or
I'll call in.
Throw us a real stumper.
Right. Well, we're getting down to a minute left in our program. Let's give some phone numbers again.
Yeah. So for people who want to find me on the internet, you can find me at Dr. all spelled out w.org, drw.org. And I'm Dr. Joe Wiersbecki. And I'm with Florida Orthopedic Specialists, and our telephone number for either the Stewart office or the Indian office, well, Stewart office or Port St. Lucie office, is 772-335-4770.
Okay,
772-335-4770.
And let's save a show for Bethany to have her come out and talk about cosmetic surgery.
Yes. Yep. First Thursday of every month, right?
Yes. Okay. Well, Joe, thank you again. We're on a roll. I'm glad you're here. We got a lot of information to educate this community. Okay, and we'll be back again next week on The Forum.